very good evening, everyone. A warm welcome to all of you who have joined in and logged in for today's discussion. Voice of Healthcare brings to you a very interesting discussion around the topic of workplace wellness that has lately been the need of the hour, as I was discussing just a while ago. The topic of today's discussion is enhancing workplace wellness, why it matters. Today's panel consists of our leading industry experts who will be sharing their opinions around it. And allow me to now introduce our panelists. We have Mr. Neeraj Lal with us. Sir is Chief Operating Officer, Gujrat region at Apollo Hospitals. Welcome so much, sir.
Hello.
We have Dr. Aloke Mullick. Sir is Group CEO at Omni Hospitals. Welcome, Dr. Aloke. Thank you for being here. We have Ariba Khan. She is founder and CEO at jumpingMinds. Welcome, Ariba.
Thank you. Hi, everyone.
Hi. We have Jeff Dickstein with us. He is Director Business Development at Lifespeak. Welcome, Jeff.
Thank you, and good evening, everyone.
Jeff will also be leading this conversation with us and will be our panel moderator for today. So thank you so much, Jeff. And without further ado, I'll hand it over to you. Over to you, Jeff.
Well, thank you very much. Again, my name is Jeff Dickstein, and I work for an amazing company called Lifespeak, which is a digital health education platform. And I wanted to share some words on compassion fatigue from one of our experts. We have a platform that's full of hundreds of world-renowned experts. And without further ado, Kushba, maybe you can play the video and we can pick it up from there.
Frontline workers typically choose these careers because they genuinely want to help. Their workdays consist of responding to situation in which members of the general public are experiencing some of the worst moments of their life. At times, they experience these situations while they are in progress, but more typically, they are there to provide assistance to very distraught individuals shortly after something traumatic has happened. The victims range from those in tremendous distress to those in complete shock or disbelief. A frontline worker's ability to care is what makes them good at their job. Their experience of losing the ability to empathize or sympathize appropriately causes them to feel lost and at times unrecognizable to themselves. Compassion fatigue is insidious. It creeps up on frontline workers. They start their career being eager and wanting to make a difference. After the first few less than favorable outcomes, the eagerness fades. After many public interactions in which they are continuously seeing people in distress, some begin to feel hopeless and like no matter what they do, they aren't making a difference. The things I hear regularly are that they're tired of seeing people treat each other poorly. They're tired of seeing people make poor choices, and they're tired of seeing bad things happen to people. They talk about nothing changing, no matter how many people they save or no matter how good they are at their jobs. There is often an anger about this, coupled with feelings of hopelessness.
Okay, so I'm sure you're all very familiar with this throughout your history, throughout your amazing careers. I'm sure you've come across this. Just to summarize for the audience, compassion fatigue is a term that describes the physical, emotional, and psychological impact of helping others, often through experiences of stress or trauma. It's usually brought about by a stressful workplace or an environment, lack of resources, or excessive hours, or a combination of everything. The symptoms usually are rapid in onset and are associated with a particular event. Up to 1/3 of practicing clinicians could be expected to be suffering from burnout if assessed cross-sectionally. More important, there has been an increasing trend in the emotional exhaustion of clinicians over the years. And in fact, I did a little bit of research. There was a study that was done just at the onset of COVID, a research study that was done in India by the WHO, which cited that overall 52.9% of the participants had the risk of psychological distress that needed further evaluation. So I don't think that India is an outlier. I believe we see this in most countries right now. We feel that, or we see that compassion fatigue is it's almost the last part of COVID that hasn't been treated. You know, we were discussing a little bit before. So this is our conversation for today, and I'd like to ask a few questions from the different panelists and see if we can have an interesting conversation. So actually, my first question is for Mr. Neeraj Lal. You have an incredibly vast and long career in the healthcare space. You've been working in many senior positions. While compassion fatigue is not new, how does it compare pre-pandemic and post-pandemic, or where we are today? And in your opinion, are we doing enough research? Are we spending enough time evaluating and researching this phenomenon?
Thanks, Jeff. It is interesting questions. I think everybody is talking about COVID. I would not say that compassion fatigue is under research topic. I think because of this pandemic, this term is highlighted more. Earlier, we were not talking about this compassion fatigue. In this extraordinary time, I think people are talking about this term. Like in one of the South India hospital, this research was done among doctors, nurses, paramedics, and employees. So they have not hardly seen any change pre-COVID and post-COVID. In fact, this compassion fatigue is there across all level, pre-COVID and post-COVID. There is hardly any difference. If you see, as a healthcare professional, most they like nurses and doctors, they require us to respond to a multiple demands, responsibilities. Some patients shout. You must be hearing in different part of the world. In India, if patient is well, then it's fine. Say for example, a few days back in Apollo Ahmedabad, there was a burns patient. There was 9 burn patient come from one of the chemical industry. Out of them, 2 died during the course of treatment because it is more than 60% burns. So once the relative came and they shouted on the doctors and the nurses, you're not showing their patients and relative. I'm sure they have died. You're not telling. And it was not the case, because burns is an area where, you cannot take the people inside, because, once the chemical burns is there, the bones are exposed. You cannot actually able to see that. So I think even a staff nurse, most of the patient attendants, they come to the staff nurse, shout at the counter. So I think it is there in the healthcare industry pre-COVID and post-COVID. But however, we are talking about these terms post-COVID. Like Times of India has carried a story about a nurse who was in our hospital, not in Apollo, but various hospitals in the state. The times during COVID. So they were carrying a story. There was a little girl who was posted in the ICU. So instead of 12 hours, she was here for 24 hours because she has to manage some patient COVID, and her father was sick. He was admitted in one of the local hospitals. She cannot able to go out. So the mother was crying on the phone, okay, you are a nurse, you are a paramedic, and you can not come and see your father. So that kind of emotional, stress these girls and doctors are taking. So I feel there is a fear among staff, pressure from the families for not going to work by putting their life at stake. What for? So what I personally feel, it is not at all a under research topic, but I think because of this COVID, we are talking about this terminology more quite often.
Yeah, no, I agree. It's interesting. When I was at the VOH conference in May, everybody was talking about how India is leapfrogging in terms of diagnostics and medical care and telemedicine and all of these amazing things that have happened in the last couple of years. And my big question to the conference was, but what are we doing to protect the goose that lays the golden eggs, right? What are we doing to protect our healthcare workers and keep them strong? And so my next question goes to Dr. Mullick. So first of all, before I ask you the question, I think it'd be interesting for me and for the other panelists and for the audience to sort of understand how did you embark upon your journey in medicine? Like, why did you choose this very noble career, and would you choose it again, living through COVID?
Oh, that's a simple one. My parents decided for me. They wanted me to become a doctor. I became a doctor. No fancy stories, no fancy background there.
So you had a choice, either an engineer or a doctor, right? Something like that?
I actually virtually became an engineer. I was selected for IIT Delhi, IIT Kanpur, BITS Pilani. But old man wanted me to become a doctor, so I became a doctor.
Well, I'm sure you made the right decision. So some experts say that younger, sort of newbie doctors are currently suffering more than doctors with more experience. Okay. Should there be, so I guess the question is, where should the awareness for compassion fatigue start? Do you think that this is something that needs to be discussed as early as medical school? Does it need to be part of your rotation when you're doing your residency? Do you think that the onus is upon the hospital when you start your first job? Like, is it the employer's job? Like, where do you think it needs to be addressed in the life cycle of medicine?
So I don't know about private medical schools, but the amount of workload which is there. But in the government medical schools, the ones in which we came through, because of the sheer amount of workload, even for students, I mean, we were all allotted beds, and patients can be demanding. They are obviously in stress, and you have the senior on top of you, and the patients to examine, and all kinds of stuff. So we had a first experience of burnout right there, right? So you experience emotional exhaustion, you experience depersonalization, you experience all the elements of burnout. Without even, in those days, burnout was not a thing. It's not a topic. It was not even coined, right? But we all experienced, and those of us, many of us, ultimately enjoyed becoming a doctor. They developed some kind of sense of social, that you're doing something for social good, and you're earning a living, at the same time you're helping other human beings. And when you're exhausted, and this emotional exhaustion and depersonalization starts setting in, you start ignoring the patients. You start snapping at them, and then you start hating yourself for doing that, right? So we all went through those experiences, and at that time it was difficult. Many people actually choose their further specialization based on these experiences, right? So I remember those days, nobody used to go to neurosurgery. Oh, all patients die. So difficult to handle, right? And many people said, oh, let me do radiology, right? I don't have to handle the patient stuff, right? I don't want to handle that. So lots of people actually chose their specialties based on the amount of burnout they experience in their various rotations, right? This I can handle, this I cannot handle. Unfortunately, in those days, there were no programs to help students deal with it. These days, colleges are running programs, and lots of these are centered around meditation, centered around mindfulness, centered around many other aspects. We can discuss them later. But then, yeah, programs are being run to get young doctors, young nurses, get a better hang of this situation, which all of them face. I mean, the worldwide, the data is very clear. Amongst all professions, the medical profession experiences burnout the maximum, right? In all countries, all
And
cultures.
are you starting to see an exodus among your colleagues, not only within your hospital, but just in general? Are you starting to see doctors taking early retirement, or are you seeing fewer highly talented people going through medical school, sort of making that decision, maybe I should be an engineer or maybe I should be a programmer. I can just sit in front of a screen all day and not listen to people.
Yeah, some
Do you-
people, yeah, that's right. At the end of their med school, some people actually, of course, people end up deciding on easy specialties where the likelihood of burnout is low. And there are people who just get out of medicine altogether. There are people who will go into IT, people who will go into general management, right? They just refuse to continue working as doctors, which is a shame.
Yeah. Do you think part of this is a question for everybody, actually. Do you think part of this is related to, I'm talking about the way patients are treating doctors nowadays, and not listening to their guidance, not following instructions, not following treatments. Do you think a lot of this stems from a lot of the innovation that we're seeing in medicine? So, for example, you're pre-diabetic and you see your doctor and your doctor says, listen, it's time for you to exercise, cut sugar, lose weight. And patients are sort of saying, well, there's a magic pill for that now. Or with cholesterol, you know what, I can take a statin, or, I can take a hypertension pill. Like, do you sort of find that the more we get advanced on one side of the scale, it makes the doctor's job harder because patients have a different appreciation or an understanding towards medicine? Like you often see that mug which says your Google search doesn't match my 10 years of medical school, right? So this is an open question to the whole crowd. What do you think of that?
Okay. See, it actually depends. What is triggering your exhaustion? I mean, the first step of every burnout is emotional exhaustion. So, based on your practice, based on the kind of patients you're seeing, your triggers for emotional exhaustion are different. Now, triggers for a doctor working in a rural area, seeing a lot of poor patients, OPD of 150 per day, hardly any medicines to treat them, and that guy doesn't have money to eat. This doctor gets stressed out. Even if I know how to treat them, I'm unable to treat them properly. That's a different kind of emotional. He gets exhausted. He sees all this and he gets so upset, so exhausted, he said nothing's going to work, nothing changes. I mean, this is a typical example of a person who is experiencing burnout. He starts feeling every day is the same, nothing is going to change, right? And as opposed to a doctor who is having a predominantly urban practice with lots of educated patients who are throwing Google at him, and he experiences stress of a different kind. Definitely, that's a different level of stress. And so it depends on the kind of practice you have, the kind of socio-economic clientele that you're having. Your triggers for emotional exhaustions keep changing.
Neeraj or Ariba, do you have anything to add to this?
Yeah, I think what Dr. Aloke was telling, he's right. I think not only doctors, paramedics as well, because I think doctors is in touch with the patient for some time, but I think staff nurses, they're in touch with the patient for full 24 hours. So what I feel, because of this Google, say for example, I'll give you one example. There is a OPD queue manager. Patients are waiting for the doctor to be seen in the consultation chambers. So most of the time, the appointment is given through as an online app. You book an appointment through a doctor's, whichever the slots are available. And they just come, and the message goes to these patients, come 10 minutes before the consultation time. So they come and they wait for the doctor consultation. By chance, doctor takes more time because they're not working like machine. Every patient has to be seen in 5 minutes or 10, depending upon the patient, depending upon the criticality they see. Sometimes they need to go to the ICU to see emergency patients, So at that time, they sit in the counters and they do a Google reviews, So, most of the hospitals are busy in management of these reviews because these reviews pop up to most of the people. And sometimes these people threat to the hospital authorities and front office, look, guys, if you will not do this, I'll put it on the social media, clicking photographs and everything. So I think, there is one website known as mouthshut.com and all. There's so many things are happening. So one of the doctor in Bangalore who was working with me, he was making a website, rogue patients. Sometimes the patients are also like that. You always blame hospitals and doctors, but sometimes, the patients are also not very friendly. So at that time it is very, very tough call to take. So I think all the paramedics and medics pass through the digital trauma, the mental trauma, and especially in the critical care. Now sometimes how to broke the news to the relative, by chance they are operating upon the patient and a doctor comes out. So now whenever he comes out, he don't know how does a patient behave. And in these corporate hospital, most of the people come from tier 2, tier 3 cities, so they come in the family as a group. Like India is a very close knit family, so 15 people come. So sometimes it is very, very difficult for them, to address these kind of people. So most of the hospital got a job profile of manager or duties. So every day in and out we came across these patients. So I think so this burnout and this traumatic stress is too much among paramedics and medics, because I think junior doctors and staff nurses take care of the patient, and most of the time they get advice from a senior consultant on phone or a digital medium. So this is happening across, especially in the small clinics and the corporate hospital, where you get the patient once he's in bad shape. So that's from my side.
Ariba, do you have anything to add?
Yeah, just a quick point. I completely agree with Dr. Aloke and Neeraj. And the digital transformation has brought a lot of information symmetry that has, empowered the individuals. And I myself have seen, patients going and first giving a Google analysis that, these are our symptoms and most probably this is the analysis, right? And doctor saying, okay, just, wait a minute and listen to me. So definitely, I think patients and individuals are becoming more demanding, more irrationally demanding, right? Because they have some information that might be biased, that might be true and may not be true, right? It's not always going to be true, and that is putting in extra pressure on the doctors, right? Because first, if, as Dr. Alok said, that if I'm already going through a burnout as a doctor, if someone is coming and posting questions and making irrational demand, that makes my enthusiasm also go down and makes it more difficult. So definitely that is something in the recent years has gone up and is making more difficult. I think my request for everyone to be watching, just listen to your doctors more than Google and help them.
Now you've done something amazing. You founded a company called JumpingMinds. Can you tell us a little bit about that very briefly, and then I have a couple questions for you.
Sure. So JumpingMinds, the idea behind JumpingMinds was that the stress level that have gone up across every gender, demographic, profession, and the idea was that there has to be a peer platform where I don't always have the time to have 1 hour session or go to a doctor, because there are other limiters as well. There is a cost limiter, there is a time limiter, there is also availability of doctors, right? So what we plan to do, we created an anonymous peer-to-peer platform. The idea is called the friends therapy, that whenever you are stressed, you can always talk to a doctor, but if it's 3 a.m. and you don't have anyone to talk, right, you can come on the platform and talk to 3-4 friends and let your stress out, talk to them, gain from their experiences and feel better. So that's the entire idea of JumpingMinds, come and feel better by talking to your friends.
Okay, so I think it's a brilliant concept. We all need that 3 a.m. friend also. We don't have them sometimes, so it's nice that there's a platform that's full of them. With the increase of medical professionals seeking help, what sort of provisions are in place or need to be put in place to make sure that the therapists themselves, right, the psychologists, psychiatrists, the psychotherapists, aren't prone to compassion fatigue themselves, right? So how could or how does peer-to-peer counseling alleviate some of that burden? And are you sort of seeing that the compassion fatigue is hitting the therapist? Like, are we at that critical situation?
Yeah. Very right, Jeff. Compassion fatigue is something that is, coming in therapists as well, and especially after COVID wave one that we are seeing. And given that, doctors, including therapists, are the superheroes that we have seen over and over time and again especially with COVID, it's very important to manage compassion fatigue when it comes to medical professionals themselves. And there are a few things that we can do as a society, as a healthcare infrastructure to help, and a few pointers that we individually can do. And I'll just start by naming a few. For me, I think the first thing is awareness for therapists and medical doctors to understand what they are going through, to recognize that they are going through compassion fatigue, what are their symptoms, recognizing the triggers that, whenever I deal with a very highly traumatic patient, my compassion fatigue, gets triggered. So identifying the symptoms, recognizing the triggers, then, setting your own boundaries, it's very important. So these awareness programs, and most of the, as Dr. Alok said, that most of the doctors have now awareness, but these new doctors that are coming up and going through these more difficult challenges, right, it's very important for them to be aware of what's going through it. The second point that the healthcare infrastructure can help is resilience training. I think it's very difficult for doctors to not be compassionate, right? Because that's what they have come in to help others. So compassion is something that's a crucial element, but it's very important to be compassionate without getting over involved, right? Without getting over involved to the limit that starts harming you. So building resilience, or what is called as compassion satisfaction, that where you realize that you have done as much as you could do, as much as what it was possible, take help of your peers, and be satisfied with your own efforts. So building resilience and compassion satisfaction trainings that can be given to medical professionals is something that can be done. The third thing that the infrastructure can do is peer-to-peer platforms, right? Any anonymous peer-to-peer platform, if a doctor is feeling, right, a therapist is feeling compassion fatigue, if they can go to a peer anonymous platform, maybe talk to three other therapists and just share their own experience, right? What they are going through, what they are facing their patients. Sometimes talking to a peer who actually understands can be, can do wonders as well. So having a peer platform, anonymous, where therapists can start talking to each other and discussing their challenges. So these three things I can think definitely the system can start helping out. A few other things that as individuals we can start doing, right, is first self-care and mindfulness, right? Focusing on my own, getting a balanced diet, focusing on my sleep, getting more physical exercises, setting my emotional boundaries, right? To what level I should be emotionally involved, and have a boundaries so that I can let go. uh, Second thing I think that can you individuals can themselves do is, right, stay close to their own loved ones, right? Sometimes we feel that compassion is for yourself is the prime most, right? We can have compassion for everyone, but sometimes doctors forget to have compassion for themselves, right? So when you are close to your family, your loved ones, you remember that you are much more than a doctor, right? You are a human being yourself. So that is very important, making a work life balance, staying close to your family and friends. And finally, I would say, if it's getting too much, recognize that, do start doing this self test, make a list of 10 items that you see usually you go through when you face compassion fatigue. Start measuring and recording it, and if you think it's going above, do definitely talk to another medical professional that can help you out. These are the few pointers that I think I have also, talked to my circle of doctors who are, close to my network. I talk to them that they should focus on their themselves as well, right? I think that's it from my
Yeah,
side.
you excellent answer. You touched on so many interesting points. One of them being the anonymity, right? Sometimes as a doctor, you have this sort of facade that you've done all this studying and you're here to help other people, so you don't really have time to help yourself. And then you mentioned self-help, and you mentioned the things that people need to do: diet, sleep, exercise, being in tune with themselves. Um, amazing, amazing.
Just one more point I would like to add, Jeff, there. I think the last thing is to believe in yourself, right? I
Yeah,
think to acknowledge that you are going through compassion fatigue doesn't mean that you are not doing a good job. It means the opposite. It means that you care more than you should actually, right? So just believe in yourself, know that you are doing good, and reach out to the peer network if required.
yeah. Well, I think also
Thank
one
you.
of the things you said is the level of awareness, right? Like sometimes when you're in a profession and you've been in that profession for so long, whether you're a banker or whether you're a lawyer, whether you're a doctor, you sort of feel like you're the king of your domain. Like you really understand your profession. And you had mentioned like you need to be aware of the signs. And there are a lot of doctors or nurses or people who work in healthcare in general, not necessarily physicians, who just aren't aware of the signs. And I think that's why our platform, Lifespeak, when we give it to hospital groups, that's one of the best things that happens, is that people understand, whoa, I have a problem, right? Like they listen to Jana Combry, who we were watching before, like, whoa, this is me. I need to get help, right? And so it's amazing that there are companies like yours, like mine, that are here to help people who are feeling this. And the next question is for Dr. Mullick, and we sort of touched on this before. We were saying like, when should medical schools or hospitals be creating more awareness around this phenomena? What is your take on the government? Like, at what point does the government need to be further involved? At what point does the College of Physicians need to be involved? Like, this is turning into, I don't want to say a national emergency, but it's when your healthcare system is sort of capitulating from within. It's a serious situation. So what is your take on that, Dr. Mullick?
Yeah, the government is already getting involved. I mean, as part of the curriculum evolution of the undergraduate medical programs, even at the time of all medical students in India, they have a 4 weeks of onboarding process before their formal training starts. And in that onboarding, they have to undergo a fixed number of training lectures and practical experiences, which are connected to emotional intelligence, connected to, I've taken those programs, and I'm a meditation trainer also. So we have gone and helped young medical students, help them meditate, help them taken classes on burnout and joy. If you want, I can share a couple of slides from that. It's very interesting. And these students who have not yet experienced the stress of seeing patients, stress of seeing suffering people, stress of being overworked, we tell them, guys, you're going to get into this, and this is how you can stay away from this. Just a minute, if you just permit me. Okay, it wants me to upload slides.
It's okay. Maybe they can be shared afterwards to people.
Yeah. So those are very interesting platforms. The first 4 weeks, and then many medical colleges, I can in Hyderabad, in Pune, in Mumbai, all across India, have signed up for these kind of programs, which are ongoing. In the first professional, second professional. We have run these programs in corporate hospitals for doctors, for nurses. Nurses are the most involved. As Neeraj said, 80% of care is delivered by nurses in a hospital. And they are the ones who are most ignored and the most likely to get stressed. So, when we run such programs, the nurses are the first volunteers. And then we have so many success stories where the nurses came and they had tears in their eyes and they said, we could sleep for the first time. We could feel a sense of happiness, sense of joy within after doing all these things. There are lots of, and the commonest, of course, not everybody can meditate, but people can do simple things better. There's this beautiful story about Mother Teresa and her sisters of charity, and these young girls who used to come from all over the world and work with them and work in very trying circumstances with a lot of suffering people. And she had a rule for them. Every 2 years, you have to take 6 months off. Take a break. Go recharge yourself. You can't keep giving permanently. You'll run out charge. You'll get totally exhausted, and then you can't give your heart and soul to whatever you're trying to do, even as a doctor or as a nurse or as a missionaries of charity person, right? And this was a rule which cannot be broken. You've done 1 year, 1.5 years, you have to go on 3 months leave. This I try to do in my hospitals, right? Anybody, I have a simple rule. Anybody asks for leave, I never deny it. Even if tomorrow is a major hospital programs, I will never ever say no. People know that, right? And I encourage all my HODs and all the people who report to me to do the same to their employees, right? So a person needs leave, ask for leave just straight away. You know that, he knows that. He just has to ask and he'll be given leave, right? And second is, if somebody is not taken leave for 3 months, we insist you take some time off. We insist.
That's amazing. It's an amazing. It sounds like an amazing place to work.
Yeah.
Neeraj, do you feel that the government is working hand in hand with the doctors, with the hospital groups? Because the government gets a budget and the government has to prioritize according to the budget. Do you think that the collaboration between the government and the hospitals is where it should be, or do you think things need to improve so that our situation with compassion fatigue sort of plateaus and subsides?
You are right. Actually, in India, health is a state subject. So every state behave differently with the hospital setup. Say, for example, since I operate from this part of India, so here government of Gujarat is very active. I'll give you small examples. They have asked like Chief Minister House, Raj Bhavan for Governor and very Minister's House. Our team of ER, they have done a basic level of training for their CPR. So what they have done, they got generally in their CM house in the Raj Bhavan, they got 50 to 60 staff posted inside their houses, right from security guard to their cooks to various assistants, office staffs, and all those things. So by chance something happened to the minister or to their family relative, they take entire healthcare machinery on a task. So what we have done in association with them, our team of ER consultants and some of the doctors went there. They hosted the team there. It is a half-day function where Chief Minister as well as Governor himself was available for the CPR training. Followed by, there is a police training academy in Gandhinagar. What they have done, they have called around 500 people, across the state, and it was a 3-day workshop where everybody has been trained on the BLS. So if you see the cities like New York and all, because the police reach on time there whenever some accident happens. So if this basic level of training is given to them, we can save so many lives. And as a result, they got a different shades of training. Otherwise, a job is very, very different. So here the government is collaborating with school. They are collaborating with the hospitals to have a medical room in the campuses. Say, for example, some of the private schools in the government as well as public and private got a medical room. So availability of a nurse and a doctors is available there. Like post-COVID, when this school started for the children, because we have asked our children to keep away from screens. But thanks to this COVID, now we are giving them phones to attend the class. So as a result, a student who is in class 6, and after 2 years, he's going to class 9. The syllabus has changed from X to Y. And they're still in that thought of mind. So I've seen most of the people are not going to schools and they're having a tough time. So I think now they require a psychologist. So this government have collaborated with various hospitals. We are managing medical rooms of many schools so that our doctors and nurses can give the basic level of training and motivate them. And there's a downloading platform where a student from various classes can come talk to a paramedic as well as a clinical psychologist. It make life very easy for them. So I think, and self-acceptance, which I always say is the most difficult part, but relatively easier by developing self-compassion. So now even children are themselves consulting a psychologist, which was rare circumstances before.
Mm-hmm. It used to be a big taboo, I'm assuming, but
Yes.
Now it's okay. And Ariba, are you finding government help? Are there grants? Or is everything sort of private in your world?
No, Thanks, Jeff, for that. Government is definitely helping when it comes to especially the healthcare and mental health. Recently, within this year only, in the finance budget, we had a fund corpus specifically for improving the mental health of India, creating centers where people which can act as the first line of defense when it comes to stress and mental health. Right. The nodal agency, the National Mental Health Institute in India, is also doing a lot of works, and there are many grants that helps founders like us and startups like us, to help the government in the initiative to further create the awareness and efforts. So government is definitely helping in mental health and overall healthcare as well. Soon we'll start seeing the impact of that as well.
Amazing. So this question is for Ariba and for Neeraj, and I'd like to get your point of view as well, Dr. Mullick. Usually a family, we were talking about intergenerational homes, and Raj, you were talking about, oh no, it was Dr. Mullick who was talking, one of you, sorry, I forgot, you were talking about how the whole family comes to the doctor's appointment, and you must have these huge waiting rooms in the hospitals because you have all these, 15 people for every patient who come to the appointment. But usually, and maybe not so in India, but usually it's a healthy female in the household who takes the role of the caregiver, right? She's the captain sort of the caregiving team. And this has led to what's known as the sandwich generation, right? So you have women who are between 30 and 50. They're taking care of their children who have more and more issues. As Neeraj had mentioned, there's children are starting to see psychologists now in India. So we have interesting ways that we need to deal with our children. And something that I learned in May at your last conference is that with the eradication of diseases like malaria and other communicable diseases in India, people are living longer and their life expectancy has increased, but now they're sort of falling victim to diabetes, hypertension, sort of more Western type pathologies and diseases. So you have the sandwich generation where the primary caregiver in the intergenerational home is like an octopus taking care of everybody at the same time. How do we address the compassion fatigue of these caregivers, right? So these aren't your doctors and your nurses and your healthcare workers, but they're an essential part of the healthcare team. Because if we don't have somebody at home who's administering all of the treatments, then we haven't really gotten anywhere. So how are we partnering with this caregiving team, right? Like, how are health professionals and hospitals addressing compassion fatigue with the caregiver, not with the patient per se, and not with the nurses and the health team, but the actual caregiver in these homes? How are we dealing with it, and how could we be doing a better job?
So that's an interesting observation. Yeah, I mean, there are parts of India where we still have big joint families. So some senior lady is the caregiver, is the unofficial caregiver for everybody who's got a broken bone or a cold or anything, right? And but then most of India families are unitary. And there also this caregiver concept comes in a very much more intelligent way. Somebody is sick or daughter-in-law is expecting. So some senior lady will drop in for a couple of months. They take rotations, right? And that's a brilliant way of managing the workload, right? So 2 months, one lady will come, another month, another lady will come. Sometimes a senior sister might come, sometimes a mother-in-law or from the husband side or from the wife's side, and that's how they manage it. I think that's a brilliant way of doing this. And in permanent kind of joint family systems, quite more often than not, there will be several senior ladies. And those kind of families are slowly dissipating, but they're still there in semi-urban India and in rural India. So there will be more than one senior ladies who will take this role, and probably they will alternate between each other, and they enjoy doing this. So for them, it's not a core. They've been doing this for generations. So,
And how was this impacted during COVID, where the elderly were most vulnerable, right? Especially pre-vaccines, right? The elderly were the most vulnerable, and obviously lots of deaths. So a lot of the matriarchs in the family,
Yeah.
some unfortunately disappeared. Did this put like an incredible? Did this have an incredible negative impact on the family unit? And even with quarantines, right? Like you can't have somebody just drop in for 3 months. So how was it affected, and what do we
We are
need
a
to keep in
society in
mind?
evolution. I mean, people are educated. People are getting educated. Most of the ladies are joining the workforce, even from tier 2, tier 3 cities, and so lots of social customs are changing. Earlier, most of the ladies were homemakers. Now, most of the ladies are working. They're professionally qualified. They must work. They should work. And but then the big problem happens, like who's going to take care of the child? Now the young mother might take time off from her work for 6 months, 1 year. She has to join back. So either she has the comfort of some senior lady coming and staying with her from the family group and taking care of the child, or the child is given in a creche or a daycare center or something, which is obviously less than ideal, right? Every society develops some kind of a coping mechanism. We are a society which is in evolution, I would say. I saw this wonderful concept in Indonesia. Indonesia, incidentally, every girl works. Though people might think that it would be a conservative country. It's not. So every lady works, and they have a very very fine distribution of labor. So in the easy industries, like in the city, like in the hospitals and in the malls, the women will work. And the difficult industries like the mines, etc., the men will work. So in my hospital, 80% of my staff were women, including my refrigeration engineer, my mechanical engineer, my electrical engineer. All were ladies, right? And many of them during my tenure, several years there, they went into the family way. But in the fourth month on the dot, they were back on job. So I asked them, "Okay, look, do you have a maid at home?" She said, "No, no, no, we can't afford a maid." So where do we leave the child? They said 3 months, 3 to 4 months, we just wean the child and leave him with the grandparents in the village. Okay, so by the 6th month, the child needs to have a primary caregiver. The primary caregivership is transferred to the grandparent. Now the child doesn't have to go to some crash, or doesn't have to go to some nonsense like a daycare. He is living in a healthy environment, living with his grandparents. They are also teaching him something. And the child's parents, now they visit their parents more often because their child is there. And by the time he's 4 to 5 years old, when this primary caregiver, because if you're a pediatrician, any pediatrician tell you, I'm sure Ariba also must be knowing that within the first 4 to 5 years, the child needs to be near the primary caregiver when he's awake. If he's not there, if she's not there, mostly it's the mother. And if the child finds himself that I'm in a crash or I'm in this thing, he gets terribly, terribly distressed. Terribly, terribly, and that ultimately comes up in future psychological issues with the child, right? And here is a wonderful, wonderful system. In Indonesia, everybody does this, right? So we as a society also are a society in evolution. We are trying out various things. I've seen some families doing the Indonesian thing also. So ultimately, we'll evolve into something which is healthy, which will take care of many of these things, right?
Yeah, it's always good to take best practices from other countries,
Yeah,
other
absolutely.
societies. 100%. Ariba, I know your platform is anonymous, but do you have any idea of the percentage of users who are health professionals versus caregivers?
So the percentage of people who are health professionals on the platform are around 20 to 30%. Majority of the rest are caregivers on the platform. And to that effect, Jeff, just to answer your question, how did we manage in COVID, right? When there was this extreme pressure on the system, and as we say that necessity is the cost is is the root cause for innovation, right? And a beautiful thing happened that even in small households, female was not anymore the only care provider. The younger people, the male members of the family, started pitching in, started caring in all members. So it became like as Dr. Alok said, that it became a distributed system, right? And I saw it in many places, right? No more only the female member was responsible, and that's how India is progressing very smoothly, where everyone is now understanding their own responsibilities, and female is not the only main primary caregiver. And you will see this usually happening, especially more in tier 2 and tier 1 cities, where male members are coming forward and helping, right? But in tier 3 also, when the stress became too high, right, everyone started pitching in and helping, and that's how we managed it during the COVID-19 specifically. um, and to add to your question, how hospitals can start helping the caregivers, right? I think you said one very good point, that when in India anyone is sick, right, whole family comes in, right, to the hospital, or try to at least, right? And I believe that point is a very good point, right, where the families are waiting outside in the waiting room to have some session, to have maybe a video displayed that talks to them about compassion fatigue, right? Because healthcare professionals still know something about compassion fatigue, right? But these caregivers, they don't know as much about what's compassion fatigue. For them, it's 24/7 taking care of their family members, and if they fail even one person, then feeling the guilt, right? So having that point where everyone is there in the hospital room, waiting room, telling them, making them more aware, and conducting maybe open discussions. When the person is going through the taking the consultation, there can be open discussions where the family members start discussing about how difficult it is for them, as they are also getting the second hand trauma as well, right? So these are some things that we can start doing as a hospital, as the society as well, to help these caregivers and make them more educated and aware.
So that
And
actually leads. Sorry, Dr. Mullick.
no, just to add to Ariba, there are lots of these the pressure valve release mechanism built into the society. I still remember these days people don't use it that much, but when we were young and our mothers used to, वो हिंदी में बोलते हैं मायके जा रहे हैं, right? The mother used to go to her place, and she is just letting off steam. She is just going, letting down her hair and recharging herself, right? And this was an annual ritual. Once in a year, she has to take 15 days off and go back to her mother's place, right? And now most of the Indian families, they may not be going back to their mother's place, but they're going on vacations, right?
Yeah.
Everybody is now, vacation is part of the normal culture. Yeah, let's go somewhere. Let's drop everything low, go somewhere, right? And even during the COVID, I said there was apart from, as Ariba was saying, the guys also got involved. Society got involved. Even in cities, big cities, where in a colony, in a society of, say, in a gated community of, say, 1,000 household, and their WhatsApp group, it will be published that so and so house has a COVID patient. They will publish it. I mean, that is the level of openness that the society has for letting others know that I'm sick, right? And then people from within the community will volunteer. Okay, you don't have to cook food. I will get you lunch and I will get you dinner. They used to keep food boxes in front of the door of this house. So, okay, for full 15 days, this house which has got a sick person, or maybe two sick people, they don't have to cook their meals. Somebody from the community will come and put meals on the doors. Everything is gratis.
Yeah, I had that too. That was my actual experience when I had COVID. I would have these random knocks on my door, and I would open it up. Somebody was already running down the stairs, and there was like a home cooked meal waiting for me.
It's beautiful.
It was an easy week.
Community involvement.
It was a nice week. I want to take what both of you have said, and I want to pivot now to Neeraj and talk about how outpatient care could be sort of bolstered or augmented to help the caregiving team, like the lay person caregiving team, How does it need to change? Because I just read an article in I think it was the Hindustan Times, where the ratio of doctor to patient is definitely going, like it's one doctor for more patients now, so the ratio is going lower, I guess. I don't know. How can the outpatient care be improved so that we can best utilize the resources and the family structure that we have now?
Okay, something which we have experimented and which is working very well in the OPD setup, we have installed in one of the hospital AI cameras for capturing of the emotions. Like it helps to identify the patient emotions and their needs. So the healthcare professionals, they address these patients with counseling and communication. Say, for example, for emotion, happy, sad, irritation, if it is captured in the OPD through AI cameras, then a care manager can see one old man or a lady is not very happy. They proactively see the AI cameras, go close to the patient and say, I understand you're not very happy. You're very, how can we help you? And they come close to them. They help them, whether it's a billing issue or a doctor consultation issue, or they want something. So it has helped not only for the patients, but also for capturing the happiness index for the staff. Say, for example, or a doctor, say, for example, they are coming in the morning with 85% happiness index. While they go out, they are 40% or 30% happy. So it means their happiness index has gone down. So proactively, they'll get a call from the vertical HOD or a HR head. Hey, doc, why you're not so happy? What hospital has done for you? How can we help you? So I think if somebody asks to you these questions, you feel, oh, somebody is actually taking care of myself. I'm happy or not. So I think it is one of the things. Like in Apollo, we started a family day post-COVID. We are doing a family day on every Saturday. It has been seen in Apollo, most of the employees are working, they're more than 10-year-old. And I came to know most of the families don't know where their husband or spouse is working, in which place, what are their colleagues, what is their working environment and all. So every Saturday, 10 families is selected from the random selection, right from doctor, nurses, and paramedics and all. We invite their families, their wife, their kids, their parents. We send the vehicle from our hospital. They come in the afternoon. We host them lunch, and we tell them about the hospital. We take them for a round. We actually take them to the place where their husband works. So they feel very happy. They feel they are a part of the system, and hospital is not a place to come most of the time. So this family day is a big hit. Every Saturday in the afternoon, 10 family members coming with the family, and we give a lot of goodies to them. We click photograph with them, and they feel a part of a system because their husband or their spouses spend more than 10 hours every day in that hospital. They get to know what kind of settings they work. So it is actually working very well. Then awards and acknowledgement of the staff for small things. I think acknowledgement and appreciating the people, it makes a difference. Like, say, for example, a OPD executive working in the OPD, she has missed her lunch because of a number of patients are more. If some if like we go in some of the restaurant, I know there's a culture in Ahmedabad and Bangalore, I've seen, whenever you go there and somebody whisper it is his birthday, they come with a cake and they jump and dance along with you. So you feel so happy, so why they're doing this thing. So these kind of thing we used to do. Like there is our credit department, they got X lakhs of rupees from one of the corporates, so we celebrated with the cakes. So this happens. And some physical activities, like what they say, cultural yoga with the team, some organizing the social activities. I think these are the things will make the staff happy, and atmosphere which is very thanksgiving. And I think a little bit of appreciation is very, very important. And town hall is one of the most important thing, where no formal meetings were there, anybody and everybody can comes on the stage. Like when I was in Chandigarh, there is sector 17, where anybody can go on the stage, sing a song, play a guitar. There is no formalization of anything. So I think these things help, and people's stress level will go down.
Amazing. Well, we're out of time. I think Shubhu is going to come back on, but I really learned a lot today from all of you. I mean, my platform is going to be launching in India in the fall in a couple of months. And every time I speak to experts in the field, I learn an amazing amount. So I hope you all learn from each other. I definitely learned from you. And I hope we're on our way to combating compassion fatigue as efficiently as possible.
Definitely. Thanks for the session. Thanks everyone for so many insights.
Enhancing workplace wellness. Actually, it matters.
Yes.
Very true.
You have
A happy staff